This is our project on Usher syndrome. Usher syndrome is a recessively inherited disorder, which affects the audiovestibular system and vision. It involves combined sensorineural hearing loss and visual loss because of retina degeneration. Of the syndromes that include symptoms of deafblindness, Usher syndrome is the most common, with approximately 50% of adult cases with deafblindness. There are 3 clinical subtypes, distinguished by the severity/progression of the symptoms and whether or not balance is affected. Usher syndrome 1 is the most severe and includes congenital profound hearing loss and absent vestibular function. Usher syndrome 2 is the most common subtype and includes congenital moderate to severe hearing impairment and normal vestibular function. Usher syndrome 3 is rare and hearing loss is progressive with variable vestibular function. Symptoms of Usher syndrome include night blindness and deafness. This picture displays a comparison of typical vision and night blindness. On the left of the picture is what should typically be seen at night, with shades of colors and the occasional dark areas. On the right side is what a person with night blindness experiences, with almost completely dark areas. Usher syndrome type 1 may be present if a child is profoundly deaf from birth and slow in walking. 10% of congenitally deaf children have Usher syndrome. However, there are many other syndromes that exhibit signs similar to Usher syndrome. There are a few ways to reach a diagnosis of Usher syndrome. The simplest approach is to test for characteristic chromosomal mutations involving genes in charge of the function of the inner ear and retina. Another approach is electroretinography, shown in the picture to the left. ERG is an eye test used to detect abnormal function of the retina, which is the light-detecting portion of the eye. The light-sensitive cells of the eye, the rods and the cones, and their connecting ganglion cells in the retina are examined. This may prove uncomfortable for children, however, because of the electrode placed on the eye. Parental consanguinity, where parents are descended from the same ancestor, is also a significant factor in diagnosis. There are many audiologic assessments that can be performed for Usher syndrome. One of these is auditory brainstem response. It is performed by placing electrodes on the head to record brainwave activity in response to sound. It gathers information about the inner ear and neural pathways. This picture shows the neural pathways for ABR responses. Another audiologic assessment is autoacoustic emissions. This involves placing a small probe into a patient's ear canal. When sound stimulates the cochlea, outer hair cells vibrate and produce a sound that echoes into the middle ear. Autoacoustic emissions measure sounds given off by the inner ear when stimulated. There are additional measures such as tympanometry. To perform tympanometry, a soft rubbery tip is inserted into each ear and the pressure in the ear canal is changed. This measures a few things, including how well the eardrum is vibrating when sound strikes it, how well obstacle and the pressure in the inner ear. Another impedance measure is acoustic reflex measurement, where loud tones are presented to each ear to determine whether acoustic reflex is present. It examines the middle ear to see if muscles in the ear contract in response to stimulus. These are the audiograms for Usher syndrome 1 and 2. You can see in the first audiogram for Usher syndrome 1 that the patient's hearing is sloping from moderately severe to profound. In the second audiogram for Usher syndrome 2, it is sloping from moderate to profound. Patients with Usher syndrome 3 demonstrate normal hearing at birth that deteriorates over time. There is no cure for Usher syndrome, although research is being conducted. Early diagnosis is key to develop compensatory skills. Hearing aids, cochlear, and assistive hearing devices such as headsets, microphones, and adapted phones can be used for hearing treatment. Patients can learn American Sign Language to communicate, which is important for overall self-esteem and progresses to tactile American Sign Language as retinitis pigmentosa progresses. Patients will also need orientation/mobility training due to vision loss, and Braille instruction helps in early intervention. Patients will typically be offered low vision services and auditory training as well. A study by the National Eye Institute and Foundation for Fighting Blindness found that high doses of vitamin A palmitate slows retinitis pigmentosa symptoms. These are our references.